patient engagement, shared decision, and making informed consent and clinical follow-up. This overall approach is most likely to improve patient experience and clinical outcome. Anesthesiologists are involved in the majority of transfusion in the perioperative period, like in trauma situation, critical care, obstetrics, and even pediatric hemorrhage. Now, blood transfusion is the administration of blood and blood products like autologous or allogenic whole blood, packed red blood cells, fresh frozen plasma, and platelet concentrate, cryoprecipitate, fibrinogen concentrates, and so forth. These products aim to maintain or restore the oxygen carrying capacity and the coagulation property of blood apart from maintaining euvolemia. Now, numerical transfusion trigger can be helpful in guiding transfusion. However, one should not miss the overall clinical pictures, particularly in pediatrics. Patient blood management is a proactive, patient-centered, and multidisciplinary approach to manage anemia, optimize hemostasis, minimize iatrogenic blood loss, and harness tolerance to anemia. Now, the overview of blood physiologies. It's worthy of note that the estimated blood volume in a 70 kg man is 70 mils per kg. That will give us about 5 liters of blood, whereas in children, it will be 80 mils per kg, then infants, 90 mils per kg. Then in the preterm, it will be as high as 100 mils per kg. And now this blood has various components, like the cellular components and then the plasma components. And the cellular components includes the erythrocytes, commonly known as the red blood cell, that has a lifespan of about 120 days. And also there's the leukocytes, also known as white blood cells. It could be granulocytes, lymphocytes, monocytes. And then platelet too is a cellular component of blood that has approximately 5 days of lifespan. The primary function of red blood cells to carry oxygen bound to hemoglobin to the tissue structures. In adults, the hemoglobin is HbA, comprising of 2 alpha and 2 beta globin chain. But the fetal hemoglobin F, has 2 alpha and 2 gamma hemoglobin chain. And now this hemoglobin is found mainly in the fetus. And then after birth, the volume and the quantity gradually declines until it becomes about 4% in the adult's life. Now for white blood cell, the main purpose or the main function is to defend against microorganisms. The monocytes will differentiate to macrophage once it gets to the tissue, and neutrophil, monocytes, and macrophage are the 3 major phagocytic cells responsible for the destruction of bacteria and other microorganisms. The function of platelets is to bring about hemostasis and then also release some fibroblastic growth factor. Another component of blood is a plasma. Now it's a mixture of water, electrolyte, protein, such as albumin, and other various nutrients. Now it is in this plasma that all other the other cells that are circulating are suspended in. And then considering patient blood management, there are 3 pillars we need to consider briefly. Because the comprehensive patient blood management program addresses 3 pillars, which one? To detect and manage anemia, minimization of bleeding and blood loss, and then lastly, manage anemia and improve tolerance. This is a pictorial representation of the 3 pillars of patient blood management. Now, in the preoperative period, we'll consider preoperative evaluation for anemia, antiplatelet agent medication, preoperative blood donation, donor-directed transfusion, then relevant laboratory screening for bleeding disorder in the course of handling patient care blood management. Now, identifying the underlying cause of anemia is key to effective treatments and optimization because there are various causes of anemia which will impair red blood, which could be from impaired red blood production, increased breakdown, or increased blood loss. The cause can be identified by a combination of a thorough history-taking examination and simple blood investigation, such as the hemoglobin level, red blood cell morphology, and then you screen for common diseases prevalent in the environment like pulmonary tuberculosis, malaria, and even helminths. Now, according to the WHO 2025, said anemia is a state in which the number of red blood cells and their oxygen carrying capacity are unable to meet the body's physiologic need, quantified by hemoglobin concentration of less than 13 grams per dl for men, less than 12 grams per dl for non-pregnant women, and less than 11 grams per dl for pregnant women. Now, geographical location is also considered when defining anemia. In our environment, hemoglobin of 10 grams, that's 30% PCV, could be acceptable as normal. So at a value less than 30% is considered as anemia for both gender in our environment. Now for the pediatric reference range, for neonates, 14 to 24 grams per DL, and then for children between 2 months to 6 months, 12 to 20 grams per DL. And as they grow older, when they get to 1 to 6 years, 9.5 to 14 grams per DL is accepted as their range. So that below this reference range, the pediatric patient could be considered as anemic. Now, iron deficiency has been implicated in most of the causes of anemia in the preoperative patients. Now, the Network for Advancement of Trauma Alternatives created clinical guidelines on how to detect, investigate, and manage anemia proactively in elective cases. Now, these include a measurement of hemoglobin within a period of 28 days before the scheduled surgery. Now, aim for a minimal hemoglobin level of the normal range established by WHO criteria. If anemia is diagnosed, the evaluation should include nutritional deficiency, chronic renal failure, and other inflammatory diseases. Any nutritional deficiency identified must be corrected. And lastly, there's a negative workup for nutritional deficiency that have already been corrected. But anemia persists, then erythropoietin should be given to stimulate hemopoiesis. Now, as part of the preoperative care too, you have to consider platelets, antiplatelet medication. The management of antiplatelet therapy in the perioperative period of the non-surgical, non-cardiac surgery patient is complex, particularly for patients with coronary artery disease and prior percutaneous coronary interventional prior percutaneous coronary intervention, as the timing of antiplatelet interruption must be balanced against competing risk of thrombotic events. The main concern regarding the use of antiplatelet agents is the high risk of bleeding that may occur during surgery. According to the American College of Cardiology, American Heart Association 2024 guideline, in patients with drug-eluting stents, percutaneous coronary intervention for chronic coronary disease who require elective non-cardiac surgery with interruption of more than one antiplatelet agent, surgery should be delayed for at least 6 months after PCI to minimize perioperative major adverse cardiac events. Now, a patient with a recent bare metal stent or non-cardiac surgery requiring interruption of more than one antiplatelet agent is potentially harmful due to a high risk of stent thrombosis and ischemic complication. Bridging therapy, usually with heparin by subcutaneous injection for 10 to 12 days around the time of surgery / procedure, can be considered during the time that oral anticoagulant is suspended if there is increased risk of thrombosis. Now, this table just shows an approximate duration of time we can stop the antiplatelets before surgical procedure for aspirin and dipyridamole, glycoprotein 1B, and 2B, 3A inhibitors. And now this is just a table to show when you can approximately stop the medication before the procedure. As part of preoperative care too, there's a consideration for preoperative blood donation. Patients undergoing elective surgical procedure with a high probability for transfusion can donate their own blood for use during that surgery. Now, the collection is usually started for about 4 to 5 weeks. Using the leapfrog approach, a patient can donate blood every week. He can donate a unit this week, and then the following week, the patient comes, they'll withdraw 2 units of blood and transfuse the old one, and then label the new freshly donated A and B, and then give the patient hematinics. The patient comes again another week. The one labeled A can be transfused, while the patient donates a fresh one for the procedure, such that when there's need for this blood during the procedure, the blood can be transfused back to the patient, especially for those who will not want to get blood from another source, allogenic source. Another method is to do donor-directed transfusion, in which a patient decides, okay, fine, I will need blood transfusion, but then let my relative do the donation for me. Now, this one is also useful in some religious adherents who may opt for this kind of blood transfusion method. Now, we have to do some relevant laboratory screening for bleeding disorders as you are preparing patients for surgery. A very good investigation that can be done is thromboelastography, which tells the quality and the quantity of platelets, Another one is clotting profile, like the APTT, with a time reference, depending on the lab you're using, 25 to 40 seconds. Prothrombin time too can be done, and then bleeding time for 2 to 9 minutes. Now, this is a diagrammatic representation of thromboelastogram, which shows the pattern of how it starts, and then the maximum amplitude, and then before lysis starts to occur. Any abnormality within these references will indicate that, yes, the platelet has, or the patient will likely have bleeding problem intra-op. Now, in the intra-op period, we'll also consider strategies for anesthesia. Like, we'll also do consider acute normovolumic hemodilution, hypervolemic hemodilution, surgical strategies, mechanical methods, antifibrinolytic agent, and then the intraoperative autotransfusion to cell salvage. For the anesthetic strategy to minimize blood loss, optimal patient positioning is advocated so that the site of surgery is above the right atrial level where possible, and then maintain normothermia, maintain normocarbia, and minimal positive end expiratory pressure, and then can also use permissive hypotension, which will minimize blood loss. We can as well do acute normovolemic hemodilution, in which a patient blood shortly before the surgical procedure, patient donates blood, and then a crystalloid or colloid is transfused at a ratio of 1 to 3 for crystalloid and 1 to 1 for colloid, and then stored so that once it's needed, it's readily available for use. Another is the hypervolemic hemodilution. In this situation, the patient is transfused crystallized shortly before procedure, aiming to reduce the need for blood transfusion during and after the procedure. Now, hypervolemic dilution is easier and less expensive than the acute normal hemovolemic technique. However, this technique is contraindicated in patients with cerebral pulmonary edema, heart failure, and recent myocardial infarction, and then in neonates, patients with significant systemic infection. Other is the surgical strategies. Some of the surgical strategies will include diatemy use. Also, a skilled surgeon will do the surgery, and then there's minimal invasive surgery. And topical hematinics can be applied too, like use of adrenaline, use of hemostats, and other Surgicel and the likes. Also, use of tourniquet has been used to minimize patient blood loss intraoperatively. Also, antifibrinolytic agents can be used intra-op and even post-op. For example, tranexamic acid, which is commonly used in our environment. Others are epsilon aminocaproic acid and protein. Now, for tranexamic acid, a synthetic derivative of the amino acid lysine, which inhibits the interaction between plasmin and fibrin by binding to plasminogen. It's one that's commonly used in the environment and it's been in use for some time now. Now, also in the intraoperative period, you can do intraoperative auto transfusion or cell salvage, where there's massive blood loss. The intraoperative auto transfusion or cell salvage represents a method through which the blood loss during the surgery is collected, filtered, washed in order to be reinfused back to the patient. Now, many devices have been developed since the 1960s in order to produce autologous blood ready to be transfused. Now, worthy of note is the one that was invented in 1987 by Brigadier General Otovioma, a medical doctor in Nigerian Army, who invented the emergency auto transfusion set, the EAT set. And it's affordable and easy to use device in our environment. Now, this is a picture of the EAT set, and then you see how it's being used. It's quite easy and quite efficient too. And this is a cell salvage in which the blood is poured. Sometimes the environment can use a mesh of 10 layers to filter the blood and then transfuse. However, this method cannot be used when there's high risks of fetal contamination, or when the blood has been contaminated with feces or pus and other chemicals like orthopedic cement and all that. So this is a drawback for this cell salvage method. Now, we'll consider religious adherence people. Jehovah's Witness rarely comes to mind because some faiths do not accept blood transfusion. They say it's against their faith. However, each patient should be considered because individuals may interpret differently the definition of what constitutes a blood transfusion, such that some patients, like Jehovah's Witness as a reference, some say, if it's my blood, you can give it back to me. If it's a blood for my relative, you give back to me. That's what this place is trying to say. So you treat the patient as an individual. However, if an adult with a clear mind, who has capacity to give consent, decide that he or she does not want blood transfusion, even if that blood transfusion will save his or her life, it is unethical to proceed with the blood transfusion once the person has not given consent or has refused, that doesn't want blood transfusion. Excuse me. Now, transfusion protocols are part of preoperative blood management programs in surgical patients, describing the indication for autologous blood transfusion, including transfusion triggers, symptoms of anemia, and comorbidities. The so-called transfusion trigger is the hemoglobin VEG value at which an anesthesiologist chooses to transfuse the patient. For example, they've said, okay, once the hemoglobin level is less than 7 grams per DL, That's a trigger. However, for some conditions, and then for some surgical procedure, the excuse me, the trigger level for transfusion has been pegged to 8 grams per dl. Patients should be transfused 1 unit at a time, and the hemoglobin checked before another unit is transfused, unless there's ongoing bleeding or a large blood loss that needs correction. Hemorrhage can occur in any surgical situation in children, but it's most notable in trauma, liver transplant, cardiac surgery, major spinal, and then cranial vault surgery. Now, a high level of vigilance for perioperative bleeding should be maintained in patients with these hemostatic risk factors. Now, part of the protocol is that you provide verbal and written information to patients who may have transfusion. Explain the reason for transfusion, the risk and benefits, transfusion process and specific transfusion needs, alternative to blood transfusion, and then that they are no longer eligible to donate blood for a certain period of time, and then that they are encouraged to also ask questions. In a surgical case, it is advisable to calculate the weight-based estimated blood volume, especially in pediatric patients, using this formula for minimum allowable blood loss. Estimated blood volume, you multiply by the difference between the initial hematocrit and the desired hematocrit, divided by the initial hematocrit. Now, massive blood transfusion has various definitions, but we'll stick with it, which says that when greater than 10 units of packed red blood cell is transfused within 24 hours, or when there's a replacement of greater than 50% of total blood volume within 3 hours, or when there's transfusion of greater than 4 units of packed red blood cell within 1 hour, with anticipation of further need of blood products. Now, in the post-operative period too, we'll continue managing patients' blood need. Now, many of the intraoperative patient blood management strategies can also be applied in the post-operative period. This will depend on the etiology of the anemia, bleeding diastasis, or hemostatic imbalance. Anemia should be managed first by non-transfusion therapeutic, preventive, and treatment modalities such as limiting further blood loss. Now, limiting further blood loss could mean while providing the substrates for hemopoiesis and clotting factors for production like iron, erythropoietin, vitamin K, and the rest. Now, for post-operative autotransfusion can also be done after the surgery, similar to what is done intra-op. This is a pictorial representation of how it can also be done in the post-operative period when you want to do post-operative autotransfusion. Cryotherapy can also be used, whereby temperature is used to reduce the temperature around the skin to bring about vasoconstriction and then reducing blood loss. Other methods could be avoiding iatrogenic blood loss by minimizing blood sampling and only doing it when necessary. And then monitoring drains. Where a patient comes from theater with drains, you monitor it regularly to see how active it is, and then if there's a need for transfusion. And then you monitor patients' vital signs, monitor the urine outputs in adults, aiming to achieve at least 30 to 50 mils per hour in the adult patient. Then for these younger patients, 1 mil per kg per hour for the younger patients. Now, there are available blood components that can be used in managing these patients, like the packed red blood cells, the platelet concentrates, fresh frozen plasma, cryoprecipitate, fibrinogen concentrate, and prothrombic complex concentrates. We'll briefly look at some of their salient features as we progress. For the pack red blood cells. A unit is 350 mils. And then a unit that is transfused will increase the packed cell volume by 3% and the hemoglobin by 1 gram per dl. When stored, the 2,3-diphosphate glycerate begins to depreciate. Even the pro-inflammation and there's poor deformability and changes in nitric oxide physiology may also alter effectiveness when it is transfused. So that a freshly donated and transfused blood is preferred for use for patients. Stored at 1 to 6 degrees Celsius with a shelf life of 21 to 42 days, depending on the storage medium. Now for platelets, prepare from whole blood or from apheresis. 1 unit of platelet concentrate will contain like 30,000 platelets, and it's equivalent to 6 whole blood units and derived platelets. Those at 10 to 15 mils per kg stored at 20 to 25 degrees Celsius. This temperature range makes it more prone to bacterial contamination, and it has a shelf life of about 5 days. The fresh frozen plasma of 1 unit of about 250 mils. An usual transfusion is about 3 to 1 or 1:1 if you are transfusing packed red blood cell at the same time with fresh frozen plasma. Contains about 400 to 900 milligram per unit albumin, protein C, protein S, and then anti-thrombin. Cryoprecipitate is another one. Prepared from cryoglobin fraction obtained by thawing fresh frozen plasma. Contains factor 8, von Willebrand factor, fibrinogen, and fibronectin. Fibrinogen concentrate is another. Normal plasma concentration of fibrinogen is about 200 to 400 milligram per dl. And then fibrinogen is a major structural component of the clots. Critical and minimal fibrinogen level needed for clot formation in the bleeding patients is 1.5 to 2 grams per liter. Now, fibrinogen concentrates are superior to fresh frozen plasma. For prothrombic complex concentrates, contains vitamin K dependent clotting factor 2, 7, 9, and 10, and other coagulation components like protein C and S. Recommended therapy for rapid reversal of vitamin K anticoagulants. Now, there are complications associated with blood transfusion, which could be early or late. For the early, there's hemolytic reaction. However, there could be also a delayed hemolytic reaction. There's non-hemolytic febrile reaction. There's allergic reaction to protein immunoglobulin A. There's transfusion-related acute lung injury. There's reaction secondary to bacterial contamination, especially by using platelet concentrates. Then there's circulatory overload, air embolism, thrombophlebitis, hyperkalemia, citrate toxicity, hypothermia, clotting abnormalities. These are some of the immediate or early complications that are associated with blood transfusion. Transmission of infection, graft versus host disease, iron overload after chronic transfusion, and then immune sensitization like rhesus D antigen are some of the late complications that will occur. Now, for the non-infectious adverse transfusion reaction, for less than 24 hours, there could be hemolytic transfusion reaction, febrile non-hemolytic transfusion reaction, there's urticaria, anaphylactic shock, anaphylaxis, and then transfusion-related acute lung injury. For the non-immune mediated, there's transfusion-related sepsis, non-immune hemolysis, transfusion-associated circulatory overload, air embolism, and then more than 24 hours, delayed immune-mediated reaction. There's delayed hemolytic transfusion reaction, transfusion-associated immunomodulation, then transfusion-associated graft versus host disease, and post-transfusion purpura. In conclusion, Preoperative patient evaluation and treatment of possible anemia is undoubtedly the first and most probably the most important strategy that should be included in any perioperative blood management program in order to reduce transfusion rates. Strategies that help reduce intraoperative blood loss should be employed wherever possible. For the life of the flesh is in the blood, but blood should not be transfused in a competent refuser. Patient blood management is a proactive, patient-centered, and multidisciplinary approach to manage anemia, optimize hemostasis, minimize atherogenic blood loss, and harness tolerance to anemia. The future holds promises to no allogenic blood transfusion. These are my references. Thank you for listening.
Thank you very much, Dr. Ahmed, for this beautiful presentation. He has talked to us about perioperative blood management, highlighting very important factors such as multidisciplinary approach, and is a patient-centered. And the aim is to optimize the preoperative blood and treat anemia, minimize intraoperative or atherogenic blood loss, as well as patients' tolerance to anemia post-operative. So we would now like to take comments. I can't see any question from the chat box. Please, if you have comments or questions, let's kindly put it on the chat box so that we can take them as quick as possible. Either we understood this topic very well or we didn't follow. But it's a beautiful presentation. Thank you very much for that. Or if you have any question, you can signify by electronic raise of hand. I'll have to identify you. Please can you raise your hand if you have a question, or you can put them on the chat box. And while waiting for that, I want to recognize some of our consultants in the building. I saw Professor Ilori and Professor Maso. Thank you, Mark, for joining this meeting, and to various consultants that are actually available here. We appreciate you for coming. Dr. Clinton, please, you have the floor. Can you?
Good evening, sir. Good evening. Thank you for the presentation. My question is on related to ethics and of course, for an adult that has mental capacity, the presenter rightly said that if he makes a decision not to be transfused, then that stands. What about the situation for, okay, an underage who cannot make such a decision, but the parents are telling you do not transfuse because of my faith, and if you do not transfuse, you may likely lose the patient. What would you do, or what are the choices that you have? Thank you.
Thank you for that question. Any other question?
Should I respond or I should wait?
Let's wait. Hold on.
All right, thank you.
So let me read the questions we have on chat box. So one of the question is how long can we wait for elective case when someone take warfarin, and how do you reverse the effects in emergency? Can you respond to these two questions?
Okay, thank you for your questions. So far, they are well received and acknowledged. So for how long can you wait before starting elective case for patients on warfarin? Okay, it depends on the dose, because the dose will determine the effects you want to achieve. If it's for prophylaxis, 12 hours will be okay. like for the low molecular weight heparin that we're using, 12 hours will be okay. And then, but if it's for therapeutic dose, it will need a longer duration of time. I'm not very sure about our trainers will throw more light on that. And now for the reverser, in emergency, protamine is what is used to reverse the effects of heparin. So that if there's a need for emergency surgery, protamine is what is used. Now for the first question, an underage that will require blood transfusion, but however, the parents declined, what should be done and the options. Our trainer will also throw more light on this. But for the much I know, an underage is not, does not have any religion. So that if the parents say they don't want blood transfusion for, let's say, a 3-year-old, and the child needs blood transfusion, that 3-year-old is not, let me say, for example, Jehovah's Witness, that we're all familiar with. That 3-year-old is not a Jehovah's Witness, but is a parent. If there is need for blood transfusion, and the blood transfusion will save the child's life, the available option is to get a court injunction to overrule the parent's decision so that the child can have the blood transfusion. Also, maybe the elders of the Jehovah's Witness, as an example, some of them may, I don't know, they may accept so that this child should get blood transfusion. That too may be an option because, like we saw earlier on, you individualize the religious adherent people who may want or may not want blood transfusion. So that is the much I'll be able to say concerning that. Our trainers can please give us more information. Thank you very much.
Yeah, thank you for the comments. Just to add to what you just said, concerning the ethical point of view. So there are ways to go about it. First of all, you need to consider what is your cadre of the doctor that is seeing this patient. If you're a registrar, a senior registrar, it is not in your prerogative to actually go ahead to transfer or not. You have to pass the ball to the consultant. But if the consultant that's the child of the patient, there is what they call the Child Act, and the consultant also will not go ahead until they have the clinical medical advisory committee chairman, which will be informed, as well as every hospital should have the legal department, where you rightly said about a court injunction will be actually obtained. However, some people will say when it's in the ninth and you don't have the legal units available, it is important that you have the numbers of the legal units, or the CMAC is actually informed which decisions will be carried concerning that patient. But you rightly said the child does not have a religion. However, because of legal issues, you need legal backing for these ethical issues. Well, maybe our trainers also will throw more light on this question. But we have to go to the next question before we call on our prof to summarize these presentations. The next question is, you had mentioned the site of surgery in respect to the location of atria. What is the clinical significance?
Okay. I should respond, I should wait.
You understand? Please, can you respond?
Okay. Where possible, the atria than the surgical site. The clinical significance is that it enhances blood return, venous return to the heart, thereby minimizing blood loss. That's much I know.
So I didn't get that explanation. Can you come again? Can you hear me? Dr. Ahmed, can you hear me? Am I audible, please?
Yes, I can hear you. I think maybe his network skipped or something.
Okay. Let's wait for him.
Oh, are
Dr.
there
Ahmed, are you
other
back?
questions?
I didn't get you, Dr. John.
I said, okay, there are other questions too.
Yeah, I need him to be available to be able to answer.
Hello, please, can anybody hear me?
Yes, yes,
Okay.
yes, you're
Sorry for that.
audible.
Okay.
All right. So the next question is, what is the target MAP in? Permissive hypotensive technique. Did you get that?
Yes. The target MAP should not be below 40 millimeter mercury for hypotensive, permissive hypotension. Should not be below 40 millimeter mercury. Hello? Hello?
Hello, we can hear you. Yeah, we can hear you, can hear you.
Okay.
So the target MAP should be between 50 to 60 millimeter of mercury.
Yeah, but not below 40.
Yes, yes.
But not below 40.
Any other comments or questions from the resident before we move on to our trainers? I want to recognize, so for any comment from our consultants, any comments, can you raise your hand so that we can actually identify you? And Dr. Emma, I want to commend you for keeping to time with your presentation. Well done.
Thank you.
Dr. Akinwale, sir, you have the floor, sir. Dr. Akinwale, sir, you have the floor, sir.
Hello, good evening. Can you hear me?
Yes, sir. Audible, sir.
Okay. Well, I want to thank the presenter. He has done well. Heparin with warfarin. Warfarin is not is neither low molecular weight or high molecular weight. So warfarin is an oral anticoagulant, and it works by inhibiting production of vitamin K dependent clotting factors in the liver. So for timing the surgery, if it is elective, you stop for 4 to 6 days before surgery, so as to allow the INR to normalize. Well, you also have to monitor the INR. You can do it every day or 2 days interval, so that it can be below 1.5. In emergency, of course, you can give vitamin K, you can give what you call hypothalamic complex concentrate PCC. You can also give FFP if available. And I said you can also give vitamin, but commonly they give FFP or vitamin K. All right. So that's my comment. Yeah, well
Thank you,
done.
sir. Thank you,
That's
sir.
my comment. Yeah, well done. Bye-bye.
Thank you
sir.
very much, sir, for that wonderful comment, sir. Any other consultants? Any other consultant? Okay, if there is none, I want to call on Professor Wasosa, Ma, for your remark and summary of this presentation, Ma.
Okay, thank you very much for this presentation.
Thank
It's very good and very apt. It's coming at in a timely manner, and it's similar to some of the presentations we have had recently from the WFSA. You know, we had perioperative blood management in obstetrics in July, no, in March, on the 2nd of March. I think many people attended, and we've also had another one late last year. So it's a topical issue, and it's something that everybody needs to, be conversant with and be aware of, and also know the relevant guidelines and then the medical legal issues that are involved. So I enjoin everybody to um, learn very well about this topic and have it at their fingertips. I want to congratulate the presenter. He did an excellent job, and he really went to town, and it was a very good discussion. Thank you for that. I congratulate. I know his trainers and mentors, all those that guided him through. They did a good job. It's excellent. And also thank the moderator for doing very well. So well done, everybody. And let's have more of this good stuff. More of this in the future. Thank you very much. Bye.
Thank you, Prof.
Thank you, Ma. We celebrate you, Ma.
Welcome. Welcome.
Okay. Okay. Dr. Belema, are you still speaking?
Thank you very much for having me. I want to hand over to the representative for the resident, Dr. John. Thank you very much. Thank you all for your comments and questions, and our trainers for participating in this webinar. Thank you so much. Dr. John, over to you.
Okay. Thank you so much. And I think we had a really good session today. It was a great presentation. It was great moderation. Thank you, Dr. Ame, for your presentation. Thank you, Dr. Belema, for the moderation. We are grateful for our trainers for their comments, Dr. Akinwale, Prof. Ma. Thank you for always being with us and for always being a beacon and for always teaching us and guiding us. As usual, this is the NSA Residents webinar series. We do it every 2 weeks. It is for residents. It is by residents. So the next topic, as usual, will be communicated on the group. Thank you, everyone, for joining in. We have at the time, we're over 100. Now we're still about 87 persons on here. This was well attended, and we are happy. So we are all better when we are together. So we look forward to more full houses like this, and the conversations will still continue, like I said, on the residents group. Like I also said on the group, please watch out. Later this evening, we'll be having further announcements around the research that we're doing. So look out for that. And looking forward to seeing everyone in the next 2 weeks for the next presentation. Thank you, everyone. And as usual, we are very grateful to the NSA, the leadership of the NSA for organizing this. The president-elect, Dr. Quinette Kalu, usually she's here. It seems, okay. I think the unavailable sent a message that she is unavailable today. So the president-elect and the chairman of the education committee, our leader and trainer, thank you so much, Ma, and very happy felicitations to our president, the NSA president, Professor Hassan Dati, for the support that he's giving the residents. So we'll have further discussions on the group. Thank you everyone for joining in. And the slides and the recording will be shared as usual on the NSA YouTube channel. Have a good evening, everyone, and a productive week. And a happy new month. Have a very wonderful July. Thank you, everyone.